Well, thank you everybody for making time this evening, particularly on such a beautiful and hot evening. We're determined to keep this to our time, so we will finish by 6:30, rest assured. On behalf of ACT and all of the investigators who are joining us this evening, we would like to welcome our guests and obviously particularly thank you for your huge and important support for ACT and for the research efforts that are going on in Cambridge relating to COVID-19 and the SARS-CoV-2 epidemic. My name is Miles Parks. I'm a consultant gastroenterologist here at Addenbrooke's, and I've also recently taken on the mantle of director of the Cambridge Biomedical Research Centre, trying to fill John Bradley's boots, which is no mean task, I have to say. Before we get into the talks themselves, could we perhaps just, Jenny, perhaps you can ask us or run us through the invitees and guests, perhaps just as a round of introductions, just so that we can all introduce ourselves.
Yeah, sure. So I'll start off with the ACT staff first, because I know that speakers will introduce themselves as we go along. So I'm Jenny, and I work at ACT, as does my manager Claire. And we also have Gemma, who I'm sure a lot of you know, who's our Director of Fundraising. We have Katie, who's our Head of Hospital Engagement, and we've got Emily, who's our Trust and Foundations Lead. So guest-wise, we've got Jim Potter here with us. Hi, Jim. I've got Anne Greenwood. Hi there.
Hello.
And we've got Dame Mary. Hello.
Hello there.
And we've got Abby from Cambridge Commodities. Nice to see you again, Abby. So I think that's it for our guests. So I'll let you crack on. Let me just share my screen and I'll begin the presentations.
Okay, so I'm just going to do a couple of housekeeping things as well before we got on to the presentations, if that's okay. Just to remind everybody to keep your microphones on mute if you don't mind during the presentations, just so we don't get caught out by background noise and fans and all the rest of it and mobile phones going off. That would be really helpful. We're very keen for this to be more of a discussion and conversation really more than anything else. So please do feel free to interrupt. You can either post a message on the chat, raise a hand. If somebody says something particularly controversial, feel free to unmute yourself and just butt in. That's completely allowable, and nobody will be remotely fazed by that. As I say, we want this to be a conversation about what exactly is going on, and sometimes it's good to have that actually while a particular slide is up in front of everybody. We've asked the speakers to keep to time, and I will somewhat ruthlessly cut them off if they're overrunning, or encourage them to hurry up if they're getting towards the end of their 5 or 6 minutes allotted. We do want to leave a little bit of time for questions, Q&A after each presentation, and also a sort of 10-minute conversational piece at the end as well. But feel free to jump in at any point, really. So I'm just going to do a brief introduction. As a gastroenterologist, I'm probably the least well qualified person on this call to comment in too much detail about the ins and outs of the clinical presentation of COVID-19. But I have been involved in helping to pull together some of the research efforts around this, and including the application that was made to ACT, and which you guys have kindly supported and helped to fund. Next slide, please, Jenny. So as everybody is all too aware, this has been a devastating outbreak originating in China. It's difficult to believe that it was scarcely more than 6 months ago that the first case of this illness was reported from Hubei province in China. The report of this viral pneumonia, and you can see some illustrative images bottom right here of the chest x-ray showing the diffuse infiltrates, and the CT scan likewise showing this characteristic pattern, which our radiologists have become all too familiar with. The virus was sequenced very rapidly, and the mechanism by which it enters cells fairly quickly elucidated, as you can see in this cartoon top right, with the blue spike protein on the outside of the virus envelope interacting with these particular ACE2 receptors, which line the lungs effectively in the upper respiratory tract and allow the virus to gain entry into the body. Next slide, please. And of course, it wasn't long after the first reports that the grenade really went off around the world. And as we've seen night by night on the news, the death toll rising in the UK and around the world. as this tragedy has unfolded. Next slide, please. This is the local data. These data pulled together by Ben Warren, who works in the infection department, the infectious diseases department here at the hospital, showing how this has played out here in Cambridge. I have to say, thankfully, Cambridge hasn't been too badly hit compared to other parts of the country with relation to COVID-19. Thankfully, the worst case scenarios didn't really unfold here in Cambridge. The lockdown that was imposed, obviously, from London came a little bit too late for London, but actually just in time for Cambridge, I would suggest. And I think that's one of the reasons why we didn't get too badly hit here. As you can see, though, nonetheless, we've had just over 500 cases admitted here in Cambridge, 525 cases in total, approximately 24% death rate from COVID-19. As you can see along the bottom part of the graph, this is now largely petering out. And I think the last case of COVID admitted here in Cambridge was probably 3 or 4 weeks ago. Mark Toshner will probably give us an update in the next talk on exactly where we are with regards to that. But of course, everybody is living in a state of preparedness for what might come next, come the winter and come the flu season and potentially second waves and so on. Next slide, please. And furthermore, although the acute illness is devastating, it's clear that there are potential long-term sequelae. It's not all about the acute infective illness. It's not even all about this dreadful cytokine storm, which seems to be the thing which leads to the devastating progression of the illness and requirement for intensive care and so on. There's a real concern about what the long-term sequelae may be of the acute illness itself, and potentially also the development of subsequent problems. And you're going to hear a lot more about that in the talks that follow me. We have been successful in setting up, in fairly short order, a post-COVID clinic here in Cambridge. We're very mindful that these poor people who have suffered COVID need to be well looked after as well as well researched, and we've tried to coordinate things so that we don't impose too much on them and that we don't over call them back up to the hospital. So we've set up a clinic which integrates both research and clinical care for all patients admitted at Addenbrooke's, and actually also all staff who've tested positive. This allows a systematic data collection and sampling. Very much our intention is to integrate the research programs which are being funded by ACT, and which you'll hear more about in a minute, with the national efforts in COVID-19 research as well. And I think that's important both for Cambridge and allowing the pulling together of all of these various different strands for a national research effort. Together we can do so much more. Another important function of this clinic, as well as these broad projects, is to identify potential participants for these rather specific projects, which you're now going to hear more about and which others are going to talk to. So on that note, I'm going to hand over to Mark Toshner. I don't think we need to have questions at the end of that. We'll probably pull together my questions at the end, but I'm going to hand over to Mark Toshner, who's a friend and colleague here in the Addenbrooke's on the university side and at Papworth as well, to talk to you about the cardiorespiratory problems relating to COVID-19. Mark, over to you. Is Mark on the call? Mark, you're on mute if you are on the call.
I know Mark is struggling with his internet access, so it might well be that he's dropped off of that in Cornwall.
Not to worry. Why don't we just fast forward through Mark and come back to Mark in a minute when he joins back on, and move to David. David, are you on the call?
Yes,
David,
I am. Yes, I am.
So David, I can hand over to you just to introduce yourself first of all, and then take us through your talk if you don't mind. Thank you.
Yeah. So I'm David Menon. I'm professor of anesthetics. My clinical work is in intensive care, and I work on what is normally the neurosciences from critical care unit at Addenbrooke's. And with the COVID pandemic, we expanded our critical care facilities. We normally run between 45 and 50 level 3 beds. These are beds where we can vent, and that went up to just under 90, with the capacity to surge up to 120.
David, your microphone is a bit strange. Can we if you can speak a bit closer to your mic, that would be helpful. We've lost you altogether now, David.
Right, is that better now?
Yeah, that's much better. Thank you.
Okay. So all told, across Papworth and Addenbrooke's, we saw about 225 patients in the critical care units, about 130 at Addenbrooke's and 90 or so at Papworth. Overall mortality of about 40%. Next slide, please. So quite early in the course of the illness, it became obvious and also probable that we would see neurological complications from what was initially thought to be primarily a lung infection for a variety of reasons. First of those are just the fact that these patients are very sick and they either may have low oxygen levels or inadequate blood pressures to supply oxygen to the brain. We know that the blood gets a lot stickier than normal in these patients, so they may have a thrombosis in either the arteries or the veins, causing a stroke in the brain. And then there's a whole host of immunological problems, either direct activation of inflammatory cells in the brain, the cytokine storm, a host response that's out of control. And very interestingly, we began to see some evidence that patients may be developing an autoimmunity against some of their brain and spinal cord proteins. And in subsequent literature, so this paper from our group was one of the earliest ones. In subsequent literature, we know that between 20 and 30% of patients admitted to the hospital have neurological complications. Next, please. And that was particularly interesting for those of us who work on the neurosciences critical care unit, the neuro and trauma ICU, because it's separated from the Wolfson Brain Imaging Center by one set of double doors. No, back, please. One set of double doors, and in the Wolfson Brain Imaging Center, which is the blue bit on the right-hand side of this floor plan, we have a 3 Tesla MR scanner, a very powerful 7 Tesla MR scanner, and a PET scanner. And it meant that we could take sick patients through to the scanners and understand what was happening in the brains from the very earliest point of their illness. The most common reason to do this clinically was because patients were not waking up once their sedative drugs were stopped. And we looked for neurological complications initially clinically. Next slide, please. And we saw what other people have shown. So this is fairly typical. This is a particular kind of MR scan where all the dark blobs that you see, which really flood the brain on the slice, are either small bleeds or thrombosis in small vessels. And this could be a combination of things. It's pre-existing age-related susceptibility, inadequate oxygen. This particular patient had ECMO, extracorporeal membrane oxygenation at Papworth, and had come back to us, and they can have damage from the cytokines as well. And this was useful to document, and lots of people have been doing this. But what we could offer was a slightly different thing. Next slide, please. So this is a 71-year-old man who presented with severe respiratory failure and got past his acute phase. And during a cessation of sedation, just would not wake up. He was not responsive with generalized jerking and bouncing eye movements. Our neurological colleagues made a diagnosis of opsoclonus myoclonus, clever phrase, but basically it's an abnormality of movement control. And it's been seen in other viral encephalitis before. So this patient we scanned on day 14, day 33, and day 46. And I've got the scans on day 46 on the right-hand side. And the tiny little white patches you see at the bottom of both slices are the abnormality. Now, in themselves, they're not at all exciting. We see them very often in people over the age of 60. I suspect I have some bits and pieces in my brain, perhaps not as much as a 71-year-old would have. But what made it really interesting is that we had the 2 earlier scans of this patient. And if you can go to the next one, please. The 2 earlier scans show that on the first scan on day 14, there were no abnormalities, and they slowly evolved over a period of 4 to 6 weeks. And this is really, really interesting because it suggests that whatever the process is that has been written off by many other centers as just age-related change may be because of the disease itself. And the mechanisms that have been implicated in this accelerated aging are either tau deposition, which has been involved in Alzheimer's disease, or brain inflammation, which has been involved in many degenerative diseases. Next slide, please. So is this the only abnormality? Well, with conventional MR, quite a few of the patients that we imaged, we've now imaged 16 patients in the acute and subacute phase. The MR was normal or showed only marginal abnormalities. But when we looked at this quantitatively, it was very widely abnormal. And it varied, the abnormality varied with region. The top half of the brain, if you like, the thinking part of the brain, the cerebral cortex, showed one kind of abnormality, whereas the bottom half of the brain stem, which is circled in green here, showed a different kind of abnormality. So the top part is the thinking part, the bottom takes care of breathing, cough reflexes, heart rate and blood pressure control. Next slide, please. And when we looked at that quantitatively, what we found is that the abnormalities were almost diametrically opposite. So in this, somewhat unhelpfully, I realized red is control subjects and green is the patients. And if you look at the bits in the top of the brain, the green boxes are always to the right, whereas if you look down at the brainstem, the green boxes are to the left. So in both those instances, it's very different from control subjects, but the changes are diametrically opposite. Next slide, please. And what you can see is that the top changes are more in keeping with a blood clot in the vessel. So this is neuropathology from 2 of our patients who died. On the top, it's in the cerebral cortex, a blood clot in a small blood vessel surrounded by devitalized brain, whereas the bottom slide from the brainstem shows marked inflammation in the brain, which probably we think is autoimmune. Next slide, please.
David, I've got 1 more minute for you, if that's okay. Sorry to rush you.
This is my last slide. So we have these patients who have lungs that look like this. This is a CT of a coronal section. They've had a cytokine storm. They may have developed autoimmunity. They have these abnormalities in the brain, and they've had prolonged critical care because none of the treatments we give are risk-free. Next, please. And this results in a whole host of symptoms, severe fatigue, arthritis, cardiac and respiratory sequelae, cognitive problems, a brain fog, psychological and psychiatric problems, residual neurological sequelae, and so on. And then when you get to the bottom, this strange phenomenon of a COVID long haul syndrome, where the acute illness with fever and all of the acute symptoms seem to carry on for long periods of time, often without virus in the sputum. Next, please. So we've got a whole host of things that Miles has already talked to you about. The imaging, which you funded, for which thank you very much, not just structural imaging, but also looking at the connections, the cabling in the brain, which is the middle image, or the functional connectivity of the brain. We will undertake neurocognitive and mental health elements, assessments, which Paul will be telling you about, the cardiorespiratory assessments, which Mark Toshner will be talking to you about, a background of immune function and autoantibodies, and airway assessment, which Ekpemi will be talking to you about. But because these patients can get hypoxic at home and have airway problems, we've also arranged to have continuous monitoring of their oxygen saturation and heart rate for up to 4 days so that we can see what happens when they're in the community. And then the last slide, please. It's just important to say that I'm giving this on behalf of a large Cambridge NeuroCovid research team, which includes many disciplines, intensive care, neurology, psychiatry, many specialties, nurses, radiographers, and so on, and also a lot of basic scientists, and we're indebted to a lot of organizations to get this data out. Thank you.
Just coming off mute. Does anybody have any questions they want to ask David relating to the neurological aspects? Either now, or we can pull all this together at the end if that's easier. David, I've got a quick question for you. You sort of indicated that some of these changes that you're seeing look a little bit like conventional aging of the brain or the development of Alzheimer's. To what extent is that been followed through? Do we yet know whether there is an Alzheimer's-like picture developing in people post-COVID? Is this a model for how Alzheimer's might develop?
So we know from cell culture studies and brain organoids, which are stem cells grown up to look like small chunks of nervous tissue, that infection with the virus can accelerate tau deposition, which is the hallmark of Alzheimer's disease.
Yeah.
And we also know that it can cause brain inflammation. Now we can look at both of those with the PET scanner that we have, and we have grants under preparation that will allow us to follow these patients up and see whether these things actually transpire in humans who've had the infection rather than just in a Petri dish. And it's
Yeah.
that translational science that we have the strengths for.
Yeah.
Miles, if there's time for one more quick question. This is Mary Archer. Thank you.
Yes.
That's a really rather frightening picture that you're painting, David. But my question is this. These very undesirable neurological sequelae, can they be avoided, or do they not happen if the patient does not enter the cytokine storm phase of the disease? In other words, is a preventive thing to successfully moderate the immune system so that that doesn't happen? Or is it already creeping in there in the acute phase, as you seem to suggest in the quantitative MRI?
Yeah, so the honest truth is we don't know, Mary, because what we will have to do is to get those 100 patients whom we are scanning, combined with nationwide studies, and ask whether the development of immunity to the virus is associated with this. It's very likely that there's individual susceptibility to this. But the fact of the matter is, to get over the infection, we have to develop immunity, either humoral, which is antibody-based, or cellular immunity, which is based on T cells. And if that immunity is inevitably associated with immunity against some of your self-proteins, particularly brain proteins, but other proteins as well, then a small proportion of these may happen regardless of what you do. We may be able to modulate that immune response so that it's less frequent, but we just have to understand it better first.
And I think it's perhaps worth just pointing out that the ACT grant, which you guys have very kindly helped to support, is funding, for example, scanning of people in whom those scans are not clinically indicated and who seem to have made a complete recovery. And I think this is a really important part of the ACT grant, is to really help us to understand the totality of the pathology relating to COVID-19 in a way that may otherwise sort of slip through the net if we don't really try and get to grips with this.
That's a very good point, because it may be that these changes, though we see them and we are excited by them, are completely irrelevant to the symptoms. So if we see them in a large number of people who are getting better, then perhaps we would be less worried about it. But it's really important to sort that out.
Thank you, David. Jenny, can we just slip back to Mark's presentation now, if that's okay? Mark, if you wouldn't mind, just if you're with us from Cornwall, thank you for interrupting your holiday. Just give us a word of introduction as to who you are, and then we'll get into your presentation.
Hi, thanks, Miles. Let's just keep our fingers crossed that the Cornish Wi-Fi holds up for another 5 minutes. So I'm Mark Tosher. I'm a university lecturer, and I work both at Addenbrooke's and Papworth Hospital. At Addenbrooke's, I work in general respiratory medicine, and in Papworth, I'm part of the team that delivers the National Pulmonary Hypertension Centre. So I work in kind of very subspecialised pulmonary vascular work. And in the last 4 months, really what I've been doing is almost exclusively COVID, in fact. So I've been working both on the respiratory unit in D10 in Addenbrooke's, and additionally was repurposed into a kind of low-rent intensive care physician across in Papworth, where we basically turned our whole entire hospital into an intensive care for the duration of the first wave. And so I've done shifts in mostly looking after patients in ECMO, and additionally was leading the family liaison team. I'll be very happy if anybody wants to talk about some of this later, to give some of personal sort of vignettes and opinions on that. But the majority of my work has actually been working on the research front. So I helped set up the recovery trial and the local investigator for the Oxford vaccine trial. Miles talked a little bit about prevalence, and I can give you a really, really up-to-date understanding of the national prevalence, because we have 8,000 high-risk subjects enrolled in that study. They are all swabbed every week, and as of yet, we've still to hit our first DSMB trigger point, which is 15 cases. So prevalence across the country really is a very low point, and hence why I've taken this opportunity to go on holiday, because it's almost certainly coming back. So if we go to the first slide, this has already been said, but it's important to highlight that we don't really know what the consequences of COVID are going to be yet. And what I wanted to talk today about was how the ACT funding has helped us bridge this period where we're not really clear what we need to be researching, and we're not even really clear what we need to be clinically following up, which is why we've had so many different teams involved. I'll talk a little bit about just the respiratory and the cardiovascular bit alone, but as you can see by this relatively straightforward schemata, there's just many different teams in Addenbrooke's that are currently primed to see patients. We're not quite sure who we need yet. We're at the point where we're doing our 3-month follow-ups, so we're only getting to the start of the medium-term follow-up of the patients, and even as of yet, it's not clear what is emerging as the major phenotypes that we need to be keeping an eye on. And so this has meant that a lot of the national studies, we are part of a large national study framework. I'm the local investigator for the FOSS-C study. That's a large multi-centre study being led by Leicester that is following patients up, but largely just biobanking patients. We've been very quick off the mark in Cambridge with the NIHR bio-resourcing our biobanking efforts, probably amongst the best in the country anyway. But that study doesn't really give us a lot of ability to deep phenotype patients. It really is a data collection and biobanking exercise. And where we're really let down is in the ability to do high specialized phenotyping tests, and that's where this money is going to go. So if we go into the next slide, our major question is going to be, all of the compartments of the respiratory system have been affected by COVID, and for example, the world I work in, which is pulmonary vascular medicine, the ECMO patients that we looked after, that's the extracorporeal membrane oxygenation. So they're the highest tier of support that you can do in intensive care. About 90% of them had significant evidence of vascular thrombosis or vascular dysfunction. And these are numbers we've never seen in the context of ill patients before. But the vascular part isn't even the major component. You've got the airways and the bit between, which is the interstitium, and all of the 3 major compartments of the lung are very dramatically affected. And we know that and there's many reports of the serious cardiovascular consequences. So we're quite well placed in Cambridge because we have essentially got either the local referral centres or the national referral centres to cover almost all of these areas, including the National Pulmonary Endarterectomy and Minimally Invasive Balloon Pulmonary Angioplasty Service, which I'm involved in, where that's where you send patients who've had unresolved clot and who continue to be symptomatic. We have the interstitial lung disease service in Jonathan Fould across in Addenbrooke's. We have one of the UK's premier exercise physiologists, and of course Papworth is well known for its cardiovascular setup. So we're incredibly well placed to try to define which of these areas is important, but the national funding has been slow and hasn't really provided us with the tools to be able to do that, and that's where the ACT funding is coming in. So we have put a bid in, and we will do a number of cardiopulmonary exercise tests and AMR scans as part of this. And really quickly, and I expect within the next 3 to 6 months, we'll start to define where we need to be focusing our energies. And it may or may not be in areas that I'm particularly interested in specifically. And the great thing about the grant we've written is that we will be able to flex and iteratively change what we focus on based on that kind of first round of tests. So maybe I'll stop there, Miles, and if there's any questions, we can take it from there.
Thank you. Thanks, Mark, for that overview. Questions from anybody to Mark about either the research proposals relating to exercise testing and the defects that we might expect to see, or the sort of pathology, even the sort of clinical aspects? Mark, I know you've been at the sharp end of the clinical management of these patients and recruitment to the recovery trial, which of course was the big story about the role of dexamethasone and how important that will be, and indeed the vaccine study. So Mark, you've been central really to much of what's been going on relating to COVID research here in Cambridge. Questions from anybody?
Can I ask a question? It's Gemma. Hello.
Yeah, of course.
What would you, this is a $64,000 question, but what could we do next just to be helpful? Because as you say, we funded a lot of stuff early on, and we've spent pretty much all the money that we've raised very, very quickly. But do you have any gut feel as to what's going to be needed next, maybe even to deal with the second wave?
So this is a great question. I actually think the second wave from a research perspective is probably not the where ACT needs to be focused, because I think there are big national infrastructure grants that are covering that. It's the follow up and the complications is where we're really lacking a clear kind of strategy. And so, for example, at the moment we know there are breathless patients 2-3 months now down the line who are still symptomatic. We are beginning to clarify why that is, but we don't yet have in place any therapeutic studies planned, because it's just far too early and because everybody's been focused on the acute phase. So I think this next few months is going to be about fleshing out our understanding about what the complications are, and then starting to think about how we might then address those complications. And this is all really gummed up by the fact that we still don't even actually have a commissioned pathway nationally for dealing with these patients. So the clinical service has been left with a lot of grey areas of exactly how they are going to deal with this huge possible, bipartite wave of patients that nobody yet knows how we, pay for both investigations and the treatment of. And so I think that the ability to be nimble with funding in that space when it is not clear what the clinical service is able to do will help us pioneer treatments as the complications emerge. And that's that. If I were a kind of medium or small size funder, that's where I'd be looking. I'd be looking to get in early with the areas that nationally are kind of grinding very slowly. And that includes, for example, psychological support. Even the basics of how we psychologically support these patients. We don't have a funding structure for that, and we don't yet know the best way to do it. So almost everything we do in COVID is actually a research area, whether you call it that or not, because
Mark,
it's all entirely novel.
Mark, can I ask you, we've heard a lot on the news about the problems that people with existing illnesses run into: hypertension, diabetes, lung disease, age obviously being a big factor. Can you give us a flavour? Do you see people who come in who have been completely well, who develop these dreadful respiratory complications, as it were, out of the blocks, starting off with completely healthy lungs and then run into problems? Or are most of the people developing respiratory things people with pre-existing lung disease and who then struggle with it?
So the short answer to the question is yes, we do see completely well patients. When you look at the odds ratios, when you look at the relative proportions, in Papworth, about 2/3 of our underlying severely affected patients had some of these emerging kind of classical risk factors, but about 1/3 of them were just, were very heavily weighted towards healthcare workers and were relatively well. So unequivocally, it still affects, people like you, me, and our colleagues working in the wards disproportionately. And although when you actually look at the odds ratios, they're all in the region of about kind of 1 to 2. So although there is an enrichment for patients who have other disease processes, that it doesn't explain the whole pathology entirely.
Yeah. Could I just butt in with a quick question? Can you give me an idea of some numbers? You've had a certain number of people who have been admitted. A certain number of people have died. What proportion of people actually are you concerned about will have these sequelae?
So that's a brilliant question. So across at Papworth, we had around about 120 to 130 patients, although that's very slowly crept up in the last month or two. And just about over 1/3 of those were on ECMO, so they were the kind of severest tier. So I've got a completely skewed population across at Papworth compared to Addenbrooke's, where it's a much more classical secondary care population. But of those, the mortality for the overall population was 30%. And so I've been doing the calls because I lead the clinical follow-up pathway, and of the patients, so that means only 70% have made it out to 30 days plus.
Yeah.
But actually that's quite astonishing, because the only reported series of ECMO patients, for example, 7 out of the 8 of them died. And in our hands, about 40 of the 46 patients that we've put on ECMO. Half of them have lived and come off and been decannulated and made it out of a hospital. In the calls, I would say at the moment, and we haven't collated this because this has literally been happening in the last 4 to 6 weeks, about half of those patients are back to an envelope of normal. And by that, I'm trying to be careful about how I explain it, because they are not normal, but they are.
Oh, yeah.
So while we're waiting for Mark to come back online, we've got some data on this from people who had the pandemic before us and the Italian literature that's just appearing now. And it's important to look at cultural context as well. So what comes out from the Far East may not apply to us. About 40% of patients have significant symptoms afterwards at follow-up. This is survivors. But that's significant, covers a wide range, and about a third of those is relatively mild, and then it goes on. Paul may be able to say a bit more about the cognitive and psychiatric symptoms later on.
So that's 40% of the survivors.
That's correct.
Yeah.
So this is follow-up at 2 months after the illness.
Yeah. Thank you.
I can send you the papers if you want, Jim.
No, it's okay. I just wanted an overall idea. Thank you.
Okay, I think we might have lost Mark temporarily, but I'm sure he'll come back in a minute. We can pick up any questions additionally at the end. So next I'm going to ask Pammy just to talk us through life from the ENT perspective, which has been critically important for the management of COVID patients and remains critically important in follow-up as well, for reasons that Pammy will explain to you. Pammy, over to you.
Thank you. Hello, everyone. Thank you certainly for the donation and for your time today. It's been challenging, just like my other colleagues have found dealing with the COVID-19 patients. My day job is being a laryngologist, so I look after patients who have voice, swallow, airway issues, but also the bigger portion of my day-to-day work is within a head and neck cancer MDT as a head and neck cancer surgeon. During the COVID pandemic, the height of the pandemic, my role, along with my colleagues, was about trying to rescue the airway via performing tracheostomies to try and allow these patients come off ventilators. And a lot of the heavy lifting was done by our critical care colleagues, and then we would come in later on when they were difficulties or challenges getting these patients off the ventilator to try and create a tracheostomy, which is a hole in the airway where you could put a tube in, give them a little more oxygen, but you can have them more awake and more cooperative, and hopefully get them out of the intensive care unit to the wards. Now, one of the most well-known complications of being in ITU with a tube down your airway breathing for you is the development of swallow issues. Also, this breathing tube lies between your vocal cords, and with the collection of with the trauma, the swelling, the collection of secretions, it's also quite commonplace for these patients to develop voice problems as well. However, in the patients who are not COVID, it's quite easy to access these patients. It will be easy to make contact with them, assess them, put a camera down, have a look at whether or not they still have problems with the voice, assess their swallowing, again, by using another endoscopic procedure where you put a camera down and you can feed them and see whether the food or drink is going down the wrong way. But in the COVID-19 patients, a lot of those procedures were stopped for a while. And part of that is because they are aerosol generating procedures. So any procedure that involves you putting a camera into anybody's upper airway, whether their nose or the back of their throat or the area around the voice box, can cause them to breathe, to cough. And you could get quite a lot of aerosolization of secretions that contain the virus. So for quite a while, we weren't able to do that, and we had to resort to bedside assessments. But the other impact on being able to do these appropriately, these bedside assessment, was the moving around and the repurposing of areas of equipment, and also the fact that a lot of people were sent to cover COVID wards. And that integral way in which we work, the ENT doctors as well as speech and language therapists, was interrupted for a short while. But once we started to realize the scale of the problem, we realized we had to come back to working together again. Otherwise, we're going to find that a lot of these patients, whilst they came off the intensive care unit, will be left with a lot of swallowing and voice issues. The typical patient coming off the intensive care unit who's been intubated for at least 10 to 12 days or 2 weeks sometimes, and has spent an additional week on top of that. So you're looking at 3 weeks in intensive care. When they get onto the ward, they usually have a feeding tube. And so we have to work with the speech language therapist to find a way to determine that their swallow is safe and take the feeding tube out and get them back eating and drinking. As you can imagine, the ability to eat and drink, speak and communicate normally is quite important for quality of life. And also, one of the biggest cause of death in patients post-ITU is when you eat and drink and it goes down the wrong way, what we call aspiration. And it was very important to identify these patients early on. As the pandemic waxed and waned, we had a national overhaul of guidelines which allowed us to be able to carry out these aerosol generating procedures in these patients. And we worked very closely. I worked very closely with my speech and language therapist. We set up a multidisciplinary team meeting once a week where we could discuss these patients virtually and try to deliver the care that they needed with a lot of PPE on, because again, these are aerosol generating procedures. It then became evident that these patients will likely be discharged home with some of these problems. Some of them have been sent home with altered diets, etc. But it was quite important to set up these studies, and I set up 2 studies with some of the grant, the funds from the grant, and one of them is to do with the airway, swallow, and voice. But a very important one was to do with sense of smell, which we're finding in a lot of patients and was also reported nationally. So one of the studies looking at measuring sense of smell using an objective test, a smell test, matching that to severity of disease to see whether or not we can use severity of sense and smell to predict whether or not you end up in ITU. Also to understand the natural history of sense of smell loss in this group of patients, and also to try and create national guidelines for management for future cases. One of the reasons is because patients who have problems with swallowing or voice or sense of smell, they do use up a lot of healthcare resources, whether it's coming back for further investigations, not being able to go back to work, not being able to reintegrate into society. There's a larger, wider healthcare economy, and that is not even to speak of the psychological impact. So we have this study, which is called the Odyssey Study, which looks at a sense of smell and how we can understand the natural history. Do they get better or not? If not, how we can use that to create guidelines so people do not over-investigate these individuals. And the next slide, please. The final study that we set up was to do with dysphagia and dysphoria, which means difficulty swallowing and voice problems in this group of patients. And again, this is about trying to make sure that we can deliver care to them. This study runs alongside the COVID joint clinic. All of these patients come to these clinics as part of their clinical care. They get the specialist care that they need, and we also invite them to take part in the study. And it means that we have dedicated time, equipment, PPE to treat them just as we would any other patient who was non-COVID. So we don't shortchange the patient. So the final slide, please. The final slide, please. The overall study benefits are that we're tackling important issues, and the long-term outcomes will allow us to understand the virus. And the key thing is about understanding that if there's a second surge, how we manage space, skill, technology, it just makes us better at managing these patients, especially the unintended consequences. Thank you. I hope I was to time now.
Thanks, Ekpemi. Yeah, no, spot on. Thank you for that. So it's this sort of area, sort of things that people don't anticipate, but which is nonetheless very important, and which again, the ACT grant has helped us to begin to investigate. It's not obvious, is it, that if you can't talk when you leave hospital, then that's a deep frustration for people. They can't communicate, they can't eat and drink. Very important. Anybody got any questions for Ekpemi to ask about the work that she's been doing either clinically or in the research space? Probably got time for 1 or 2 questions now before we go on to Paul. Pammy, can I ask you the sort of dysphagia problems that people run into, which sort of runs into a bit of our world, is that mainly a neurological problem? Is it a structural problem? Is it something else that's going on that accounts for difficulty swallowing?
We're finding it's a combination of things. There's definitely a neurological element, but also there's a lot of muscle wasting. Some of them have also have a significant amount of reflux as well. They've got weakness, just a fatiguing of the muscle, just from disuse, a lack of use of the muscle. But definitely we can see that there is evidence that there's a neurological component. They have a kind of what we call a bulbar palsy going on, with weakness of the muscles that would usually help to squeeze the throat to propel that food bolus down into the esophagus. And also they've got loss of sensation. So when the food touches their throat, like you and I, it doesn't activate the right pathway to get the muscle squeezing to move things around. So you have a lot of food and debris sitting around in the back of the throat, going down the wrong way, and they don't remember to cough. They don't feel the food in the wrong place to cough as well. But we're seeing that these.
Do we know if it recovers? Do we know if it recovers or not?
Yes, actually, there have been patients. I mean, while during the inpatient spell, I saw about 29 patients with the speech and language therapies, and we conducted about 15 FEES procedures in all of these patients. This is the endoscopy assessment of swallowing, and it was quite impressive to see these patients improve. At day one post ITU, all of them have severe difficulty swallowing. By day 5, you already begin to see that come down to about 70 to 60%. And then by day 14 and 21, that comes down to about 30%. Yeah. But there is a group that we worry about that, and that's why we want to follow them up long term in the clinics.
Okay, thanks, Pam. It's great to hear that people do get better from at least some of these things, which is good.
Miles, can I just make one point, that one of the advantages of having the really excellent clinical characterization that ECPAMI will provide is that we can combine that with very high resolution imaging at 7 Tesla that's been funded, so we can try and find out what the underlying neurological problems are. Some of them may be irreversible, but some of them, if they're autoimmune, may be amenable to therapy. So the small proportion of patients who have long-term problems with airway disorder might be treatable once we find out what the underlying problem is.
Absolutely.
That's an important point. Thank you, David. I suspect that may be relevant as well to the things which Paul is going to talk about. So, Paul, if we can hand over to you, just introduce yourself briefly and then take us through your talk. We're more or less to time, but we're perhaps a couple of minutes over, but we'll manage. Thanks, Paul.
Thanks very much. Thanks all for giving up your time and, of course, for supporting the work that's already been described very ably. My name's Paul Fletcher. I'm a primarily Professor of Health Neuroscience, but I'm also an honorary consultant psychiatrist. And over the last, could I have the slide please? Over the last 5 months, I've stepped back from academic work and done full-time clinical work as part of the multidisciplinary Addenbrooke's liaison psychiatry team. And the pandemic has presented us with many challenges to all specialities, and one of the ones that struck me from the outset was that I'm dressed in a very different way from how psychiatrists normally dress to interact with their patients. And this has presented us with a whole host of problems, as you might imagine. Only recently I was in ICU seeing a patient who was too terrified even to speak to me. And I couldn't get anything out of him. And actually it turned out that he has a long-standing delusional illness in which he believes he's being monitored and persecuted by alien life forms. And you can imagine what it meant to him, me approaching him dressed like that. Could I have the next slide, please? So leaving aside the logistical problems of the consultations themselves, the actual psychiatric presentations in the context of COVID-19 are really multifarious and very difficult to sort of systematically think about. And I'm going to be very, very brief. Forgive the rapidity of this. Over the next 2 slides, I've chosen to separate them into the psychiatry of the acute phase and then the psychiatry of the future, the longer term effects. And within the acute phase, I just want to touch on those that I might consider to be more directly related to the infection, and those that are more related to the broader situation, the lockdown and all of the surrounding factors. So we've already heard very nicely from David about the impact of the virus directly and indirectly on brain function. And we can sort of think of a spectrum from the physical, neurological to the more mental or psychiatric. And these are intimately linked, and we have a sort of a grey area in the middle where there are symptoms like psychosis, hallucinations and delusions, catatonia, delirium, cognitive impairment. And those are being caused by being physically ill. We know that this affects mental health, but also by the direct effects on the brain that David so nicely demonstrated. And these are, as you've seen, are pretty severe. And of course, there are also the effects of being on a ventilator, being treated. And then related to the situation itself, there are many impacts of this. I've seen instances of people with profound anxiety, even phobia related to the virus, even though they've not actually had the infection or even been in contact with someone who has. And they've developed symptoms as a consequence that are largely psychological in origin. There are general health-related factors. Many people in managing their long-term psychiatric or physical illnesses are reliant upon face-to-face communication with empathic professionals. And of course, that's been markedly reduced. And then there's the effect of lockdown stress on us all, the isolation, the economic uncertainty, all of the sundry lifestyle changes. So there are these two sort of acute effects that are having a profound effect on psychological well-being. And could I have that last slide, please? So this is deliberately a very sparse slide because I want to make the point that actually at present we can only really speculate on the longer term psychiatric consequences of the pandemic. I think it's fair to say that there will be important and far-reaching effects, and we've already heard some of those in the more physical domain. And these will occur in a sort of interesting integration of cognitive, psychiatric and physical factors. But despite the millions of words that have already been written prophesying what we're going to see, actually we can only make educated estimates on the nature, the breadth, the profundity of the problem that's going to confront us. And the need for research is really pressing. We can partly base our estimate on looking back at coronavirus pandemics in the past, the SARS and the MERS. And there's recent interesting work reviewing that and suggesting that following infection with coronavirus in the past, people have developed anxiety disorders, depressive disorders, chronic fatigue syndrome, post-traumatic stress disorder. And the authors of the paper studying this pointed out that although the majority of people should recover without mental illness, there is nonetheless going to be a considerable burden on psychiatric complications that we can reasonably confidently prophesy. What are we seeing emerging? Well, the most comprehensive study so far from Luert et al. Reviewed 62 emerging studies across 17 countries, 162,000 patients, and they're seeing high levels of anxiety and depression and also fatigue. And I think that sort of confirms what we might have predicted. Across the more general population, those who haven't been directly affected by COVID, there's been some interesting work recently from online studies following up people 1 month into the lockdown and showing that there really is a significant or a clinically significant level of increase in mental distress from individuals from when they were tested in 2019 to when they were tested 1 month into the lockdown. So all of this points to the need for a sort of joined up research, which I'm happy to say Cambridge is a very active participant in the nationwide studies, as we've already heard, so I don't need to go into that. In my own field and in my position as the clinical director of the Cambridge Neuroscience Interdisciplinary Research Centre, I think we're enormously well positioned to capitalise on a breadth of clinical translational neuroscience expertise across the university. And to do this in a multidisciplinary way, which I think is absolutely key, in ensuring that the studies that we're planning, the clinical follow-up that we're planning, is not hindered by insular efforts or siloed thinking, but actually, and doesn't draw false distinctions between the cognitive, the psychiatric, and the physical, because as I've tried to show in this diagram, they really are intimately linked, and it's very nice to be able to work with multiple disciplines in planning this. And I'd better stop there because I've gone slightly over. So thank you for listening.
Okay, thank you very much, Paul. Anybody got any questions for Paul about the psychiatric manifestations of COVID, or the sequelae of COVID, or the whole penumbra of things around COVID, which everybody is living with day to day, let's face it?
Has there been an increase in referrals to the mental health sector from the post-COVID patients?
Well, I've seen the figures for the Cambridge and Peterborough Foundation Trust. And the interesting thing is, initially through March and April, there was actually a reduction in referrals. Subsequently, that has climbed above the normal baseline for May and June. So I think we're seeing a sort of bounce back now.
Yeah,
sort of late
I would say
effect.
certainly in our clinics, we're seeing some of the impact of lockdown on patients who are just not COVID patients, but they come to see us in clinic, and there's a lot more to the problems that they're reporting. And they're reporting that psychological impact, anxiety, stress, like you say, that you've really eloquently mentioned. But it's so important to recognize it in patients who have just been in lockdown and not just the COVID patients. Thanks for that.
It resonates with what we're seeing, I think, when you look at the figures.
Yeah, I think it's true to say, isn't it, that many of us have seen a complete alteration of the pattern of referrals coming through our services, and it's a reflection on the multiple different impacts of COVID, both on other diseases which have been delayed in their investigations, people's worries around those things, the delay in diagnosis, so the presentation in a slightly different way of a variety of different illnesses. I think the ramifications of this we're only just beginning to find out about these, and this is even before we get hit by a second wave. So anybody got any other questions that they want to ask any of the speakers, really, not just Paul necessarily, but anybody or anything that we've heard about this evening? I mean, I think what we have heard is something of a flavour of the breadth of research efforts that are going on in Cambridge. It's been great to see the real coming together of the research community here in Cambridge. I think people genuinely are trying to act in a collaborative way, and I'm sure we've all got much to learn from each other, both in our approach to doing the research, but also the sort of interactions between the different research elements. And, you know, having chosen or heard from sort of 4 or 5 different specialty areas this evening, the thing that's really struck me has been the sort of commonality both of purpose, but actually also the interaction of the different mechanisms across these different areas, even when we're not really expecting them. I think we're seeing those things, and hopefully by taking a collaborative approach, we can actually make some progress in understanding this disease a bit better, and an impact on how we look after people. Have any of the speakers got any final comments that they want to make, David? I know you're actively pursuing and pushing on a number of different fronts. Any thoughts to pull together? David, any thoughts that you want to espouse from the neurocritical care perspective? You're on mute. You're on mute. David, you're still on mute. Thank you.
Can you hear me now?
Yes, we can hear you.
Okay. I just want to make a couple of general points. The first is a lot of the audience who heard our talks have been asking us about specific incidents of various complications, and I said 40%. But it's really important to say that the denominator matters. That's 40% of patients who've been admitted to hospital and have a certain severity of illness. And similarly, when we're looking at psychiatric and other anxiety-related phenomena, it depends on what the denominator is. So I'm involved in a 50,000 patient study with a Canadian colleague, which is looking on the internet at cognitive and psychological health impacts. But that's much more inclusive, but it's very likely that people who have symptoms are more likely to complete those questionnaires online. So we're still trying to find the best way to quantify the impact of these so that we have a realistic answer. The second thing I wanted to say is that there are a lot of national initiatives, and what the ACT funding has allowed us to do is within each of these to blaze trails, as it were, and be early data collectors and have hypotheses that we can put forward based on the sorts of data we've been collecting. And that's a huge, huge value. Someone asked, what should we be doing next? And I think the next thing that ACT needs to be doing is wait until we find out what's the best way to spend the money that you pull together within the next couple of months. So right now, I think we should be allowed to do the work that you've kindly allowed us to do, given the funding, and then take things from there.
Thank you, David. I wholeheartedly endorse that. It's been the ACT. I can't overstate how important the ACT funding has been to allow us to get out of the blocks and get these research programs going. Because without that, frankly, you missed the boat. You know, we're already seeing the three months post discharge patients coming through the system. The ACT funding has allowed us to capture, as David has alluded to, the breadth of severity, and including study of healthcare workers, many of whom have not, have been asymptomatic, picked up on screening and so on, but they're included in these studies, and to help us to get a sense as to what the true breadth of the consequences of COVID infection are. So I'm mindful that we're over time by a couple of minutes, so apologies for that. I just want to thank again the audience of donors. Thank you for your support. Actually, also the team from ACT for putting together both this evening's presentations, but also for your work and support of research in Cambridge. That's critically important. And also to all of the speakers this evening for giving up a bit of your time just to explain to us all what's been going on. I've certainly learned a lot, and thank you all for that. Jenny, any final comments? Claire, any final comments you want to make?
Just thank you. Thank you so much, all of you, for joining us this evening from holidays and offices and home. So thank you very much.
All right.
Yeah, and thank you all very much for the presentations.
Thank you.
Yes, thank you. Indeed. Quite sobering, but really interesting. And I'm sure the tremendous amount of knowledge that you have assembled will really help in mitigating this really rather dreadful disease. So thank you.
Thank you.
Good. Thanks all.
Thanks all.
Take care.
Bye. Take care.
Bye.
Thank you.